Well, welcome to the Head and Neck Society Endocrine Surgery Section webinar series. This is a wonderful webinar that we have arranged relative to RFA. And I'd like to welcome you all. This is Eddie Velto, and our Latin American colleagues have been very helpful to coordinate this webinar with several Latin American societies that you see listed here, including LATS, SBCCP, and the Latin American Federation of Head and Neck Societies. We appreciate that coordination through primarily Eddie Velto. And so we welcome you all. This is a case-based webinar. And so there will be two cases that Dr. Rangel and Dr. Beck will present, one on benign and one on malignant, both with videos. And then these cases and associated questions will be drawn through a very wonderful panel that we have: Lisa Orloff, Jose, and Ralph, and Catherine. There is CME available. Betty will be forwarding your evaluation forms after the webinar, and once you fill them out, then CME will be available.
And Greg, if you can remind everybody to use the chat function for their questions.
Right. We have set questions that we want to draw through the panel, and we will also take a Q&A through the chat function. I want to just briefly mention we have many non-Head and Neck Society members here, and I wanted to just describe some of the benefits of Head and Neck Society membership. This is the endocrine section of the Head and Neck Society. And fortunately, we have the president of the Head and Neck Society, Sherry-Ann Nathan, with us. So Sherry-Ann, maybe you could welcome everyone on behalf of the society and mention some or all of these benefits of membership and the site that's available through which membership can be distributed.
Great. Thank you so much, Dr. Randolph. Good evening, everyone, and welcome especially to our dear Latin American friends and colleagues. I've had the privilege and honor of attending your meetings in Peru, Gramado, and cannot wait to get back to in-person meetings because you do know how to put on not just great educational content, but have fun and party too. To have all of you attend the 10th International Conference in Chicago in July. I think it promises to be a meeting we're all going to remember, especially given how we're all yearning for in-person camaraderie. Dr. Randolph, Dr. Stack, and the endocrine section has really led the way during this pandemic with education for our residents, fellows, head and neck surgeons interested in thyroid and parathyroid disorders all over the world. And we thank you, Dr. Randolph and Dr. Stack, for your leadership. So we're looking to this panel, but also, like Dr. Randolph said, I just want to reiterate some of the benefits of the AHNS. You get discounted rates on meeting registration fees. We all love interacting with all of you and networking with surgeons and healthcare professionals that are really dedicated to the prevention and treatment of cancer. You can access the AHNS member profile that's available to the public and patient population, opportunities for research grant awards, and these awards are constantly increasing, as well as opportunities to participate on services and in leadership positions. And we have a really active group of members on our services. Also, I think access to the JAMA Otolaryngology official journal and opportunities to enroll in our specialty sections at no additional fees. So we hope some of you will consider becoming members and look forward to interacting with you. So thanks again, Dr. Randolph, for the opportunity to wish everyone.
Thank you, Sherry-Ann. And here is the online application site through which you can petition for application. All of us on the panel are available to provide advice and supporting letters and so forth for you. Any specific information regarding the endocrine section, please let Betty or I know, and here are the emails. And here are the CME, the disclosures of the faculty for today's program. And I did want to mention that on this topic, we have a very large Head and Neck Society white paper, which is the Head and Neck Society with a group of other societies, the Korean Society of Thyroid Radiology, Asia Pacific Thyroid Society of Thyroid Surgery, ETA, ALATS, and 2 European societies with a really excellent panel, and that work is underway. And then also I want to emphasize the next Head and Neck Society Endocrine Section webinar will be a joint adventure between the Endocrine Section of the Head and Neck Society and the British Association of Endocrine and Thyroid Surgeons. And that's in November. So with that, I'd like to just introduce our first speaker, but first, just briefly, Edivelto Volpi is one of our leaders and moderators. He is a head and neck surgeon in the Oncology Center in the Oswaldo Cruz Hospital and professor of the graduate course of thyroid and parathyroid surgery at the Cetrus Medical Center. Dr. Leo Rangel is chief of head and neck surgery at the State University of Rio de Janeiro. Jose Steck is a professor of head and neck surgery in the division of Unicamp State University. And Dr. Beck is a professor of radiology and Research Institute of Radiology at the University of Ulsan, South Korea. Lisa Orloff is a chief of neck endocrine surgery at Stanford in the Department of Otolaryngology. Ralph Tofano is the Cummings professor at Johns Hopkins and chief of the Division of Thyroid and Parathyroid Surgery in the Department of Otolaryngology there. And Catherine Sinclair is the chief of head neck thyroid surgery, thyroid and parathyroid neck endocrine surgery at Mount Sinai. We're very gratified to have all of these leaders in this program. So with that, I will stop sharing my screen and Leo, ask you to go ahead and present your first case there.
Okay, perfect. Thanks, Gregory, for this kind of invitation. It is a pleasure to be all among you, and I would like to present this first case of thyroid radiofrequency ablation. I hope this can really produce a nice discussion all around this. It is an honor. It is quite frightening to be all among you talking about this. This is my hospital in Rio. This is my disclaimers. I'm my course, and I would like to present this case. This is a 32-year-old female with a BMI of 19. She complains about 3 years of anterior thyroid nodule. It is readily visible and also with swelling. She had 3 fine needle aspiration that came Bethesda 2. It was a 2 cc nodule. It was hyperechoic, completely solid, regular, very vascularized in the superior third of the left lobe. So this is what the nodule looked like. And it was also very importantly vascularized, as we can see here. And it was mainly a static problem, as it was readily seen, and she was first referred to ethanol ablation, albeit it was completely solid, but they intended to do this, and she did 10 sessions within 13 months. And after 6 months, after the ethanol ablation, it looked like this small bump into the anterior area of the neck. And it was very problematic as she swallowed or moved the neck. And then we referred her to the radiofrequency, and we did, as we did, this is the radiofrequency ultrasound, as you can see here is inverted. It was, now it is a 2.9 cc, also very hypoechoic, a little bit irregular, and with still some vascularization. So I encourage you, everyone, to, as we do this, to check the measurements before the procedure. Do not trust the previous exams. And so we check here how the nodule behaves, as also we program prepare for the the insertion site. So we check the vascularization with the B flow here, like this, and then we move to the first part of the ablation, that is the hydrodissection, a very important part. So here we start the hydrodissection, that is putting some lidocaine, just 1% lidocaine without epinephrine, just between the, over the thyroid capsule, trying to move the muscles, the strap muscles and the area over the thyroid. And as this nodule was a little bit already treated and very solid and very close to the trachea, and sometimes the procedure can get some cough into this, we decided to perform some tracheal hydrodissection here between the thyroid and the trachea, moving a little bit this area. So we insert this same needle, but now with D5W between the nodule. We go over the isthmus and move a little bit so the patient can be very comfortable. And as she did already did some treatments, we opted to do some confirmation, and we did a core needle biopsy. So here we position, so we see how stiff it is, and here we position the core needle, and we get some sample for future analysis and to be sure that it's completely benign. And then we move to the radiofrequency procedure by itself. So I choose to do by the neck, all my cases. I do it seated, and then do it by the neck. So we start from the inferior part of the neck, the nodule. We try to reach the most lateral and inferior part of the nodule. So, and we start the ablation, and as we start, we instantly see the changes in the nodule's ultrasound characteristics, and we can really see the hyperechoic changes that happens very quickly, and that is because of the temperature and as we ablate the nodule. So we, in this case, we opted to start from the inferior part, but you can go from the superior, any way that you feel that is more comfortable or easier for you. So you can see here that we maintain a distance from the trachea. We can treat everything, and the patient is completely painless. As we can see, she's not moving at all. She's very comfortable. We just use that lidocaine, and with a slight conscious sedation, very light, that she can be helpful, and we can talk to her during the treatment if we need. And as we go with the treatment, we are moving upwards into the superior area. You can see two, in her neck, you can see two lines drawn with that two marks that I marked before the procedure. I marked the superior edge of the nodule in the inferior area of the nodule, so I can prepare and program my insert position, so I can reach the entire nodule with just one insertion site. So in order to make the procedure even more cosmetic and avoid some bleeding or ecchymosis during the procedure. So we can also observe here on the generator display that while we do the ablation, we have this number in yellow that is the impedance, and as the impedance increases, the watts being delivered, that is the red number, will decrease. So the procedure is set for 40 watts at maximum. So, and when the impedance increases, the watts will decrease. And so we don't need to do any more because it's not working. So after the procedure, we think that the procedure is completed. We recheck every spot of the nodule if we left anything behind, and then we use the Doppler again so we can check if there is any vascularization left in order to minimize the risk of regrowth or any viable tissue left behind. And if we feel that any area that needs some treatments or any vessel in subcapsular or inside the nodule, we can go back there and go directly to that area and redo that ablation in that area, so we can really get a thorough ablation and make the most of this this procedure and get the maximum reduction rate of this. And I would like to invite you all into this our thyroid hands-on course that will be held in Rio. Me and Verto and Gina. It is a hands-on experience. And if you guys could come, if the COVID finally allow us, it would be awesome to have you all here. Thanks again for this kind of opportunity. Thank you, guys.
Thank you so much, Leo. Very, very excellent demonstration. Let me just ask, Brendan, maybe you could keep your eye out for the chat for important questions. We did have one question from Amy Chen about if you had done a Subduxist, whether you've done that with alcohol or RFA, or is that a candidate lesion that you would treat?
Definitely, it could be a case. I didn't perform anyone yet. I don't know if people would, because it's less common, and people might think that it's still too experimental, or wouldn't do it on outside a protocol position. I would wait a little bit at this point.
Ralph, let me ask you if you can unmute. You know, Leo very meticulously outlined his candidacy. He is giving the benign nodule indication. Can you give us your thoughts about cosmesis and local symptoms and assessment of how impactful a nodule is, and what sort of needle biopsy assessment you need prior to judging a person as an optimal candidate?
Yeah, Greg, you know, especially since we're talking about these benign nodules, this becomes a value-based decision for some of these patients. And, you know, something that may bother one patient may not bother another. So in Leo's evaluation of the patient, I'm sure that this patient has been very concerned about this nodule, the appearance of it. I'm sure, Leo, she told you she's gone through how many ethanol ablations, and you want to do something to help her. So there is value for this patient in this situation. I think that we know based on the literature that if we had 2 benign fine needle aspiration biopsy results, we could feel very confident that this is a benign process, less than 0.3% chance that it would be a malignancy. I think when you're starting off, I think that's what you want. You want a sonographically benign nodule, 2 needle biopsies would be great, and a patient who is desiring to have this intervention and not have surgery. That is the optimal candidate. The size is important. I would tell you that in Leo's case, you would say, hey, this is a pretty small nodule. Why do you need to do anything about it? But for the patient, there's value. And that is the critical thing. We have to talk to our patients. We can't be paternalistic. We have to appreciate what bothers them and then try to provide a personalized solution. So I applaud you, Leo, for doing that.
So Ralph, let me just make one follow-up question. So this is a small nodule and it is a cosmetic issue. So you have another bullet in your, or another arrow in your quiver for cosmetic nodules that are small in a patient who doesn't want an incision. How does that discussion about transoral relate to the option of needle biopsy? How would you discuss that with this patient?
Yeah, Greg, you know, that's a great point. So when you have all options available, you can provide even more personalized care. So, you know, I'd like to say that as surgeons, we are really well equipped to provide the most personalized care and provide all options, hopefully, and put them all on the table. When, you know, we have a benign process, I can tell you that most of my patients now, when considering a transoral surgery versus RFA, RFA wins hands down, unless they really are scared about the needle biopsy being accurate or really believing it or having a family history of cancer. I can tell you many patients will still be very enthusiastic about RFA, even though transoral surgery exists and it's nice for us to be able to offer it. The specter of having a surgery and having complications, patients run toward RFA. It gives them a chance also to avoid taking thyroid hormone, much more likely with RFA, of course, than with surgery and transoral surgery. So, you know, I think.
Let me ask Catherine, there were some other questions relating to the
Location of the thyroid.
The location, right. So Brendan, would you, maybe we can direct that to Catherine, those questions?
Yeah,
both isthmus and lateral?
Basically, the questions was lateral, isthmus, or just in general, are there some preferred locations for this? And then there was a follow-up question, if we could show at some point a image of what a post-ablated lesion looks like in the thyroid.
Thank you. So the radiofrequency for benign nodules, you can do them at any location in the thyroid. I think different locations have different risks associated with them. And when you're talking about an isthmus nodule, as in this case, I think the trachea is obviously the main structure that we want to avoid too much heat transmission to. And I think Leo very nicely hydrodissected that away a bit to give it a little bit of a buffer zone from the heat. I would just make a note that I think the 5% dextrose, that's a very important point, using that on the trachea instead of lidocaine, because if a patient is coughing from the procedure when you're doing an isthmus nodule, it may well mean that you've got too much heat transmission going to the trachea, and you don't want to numb that by using lidocaine to do the hydrodissection between the nodule and the trachea. So I think that is one important point, because using these, actually the patient's reaction to it can give you an idea that you're too close to critical structures. And then with regards to laterally based nodules, there are a number of structures around the outside of the thyroid, the carotid arteries and the recurrent laryngeal nerve, and on the left, the esophagus, that risk, and particularly the recurrent laryngeal nerve with posteriorly located nodules. It's a difficult area to get a hydrodissection plane in, so we're talking about keeping the probe back from the capsule, making sure that that ablation zone doesn't cross the capsule, and really taking care in that danger zone on the posterior aspect of the nodule to ensure that those nerves do not get significant heat transmission. I haven't had any issues with the nerves, and I do take a lot of care to make sure that that ablation zone is kept clear of the posterior capsule. And using that technique, I've found that the patients have had normal voice and normal laryngeal examinations after the procedure.
Thank you. Lisa, let me ask you, this is a procedure that is similar but different from many of the things we do as surgeons and as ultrasonographers and people who biopsy neck structures in the thyroid. What sort of certification or preparation do you feel is appropriate as a head and neck surgeon who he or she does a lot of thyroid surgery to begin with? What sort of preparation do you feel is most appropriate or optimal in order to initiate this?
Well, thank you, Greg and Brendan and friends on the panel and the audience for tuning in. You've given me a tricky question, Greg, in terms of certification, because just like all politics is local, there's not a standard certification pathway for RFA, much less even for ultrasonography. But I think it's incumbent upon the proceduralist to be proficient in ultrasound first, and really be aware that it's not sufficient just to assess and recognize nodules.
Excuse me, we need Horatio, Dr. Ramos, we need you to mute your
There we go, thank you. It's not sufficient just to be able to assess the nodule. One has to really be able to assess the surrounding anatomy as well, because that's where the risk is greatest. And I think there's a progression from doing non-interventional ultrasonography to doing ultrasound-guided fine needle aspiration biopsy, which is usually the first procedure that is tackled on the thyroid gland. And that's sticking a needle into a target, but not actually delivering energy. And there's less risk to surrounding structures, but being really cognizant of the vascular, neural, muscular, and airway and esophagus anatomy surrounding the thyroid is critical. So that's part of our attempt to develop this white paper that you alluded to early, Greg, and thank you for highlighting that. We have an international group that we're delighted to be working with to really establish guidelines for safe RFA and related procedures, but with the critical first step being proficiency in ultrasonography and knowledge of the risks and how to best use ultrasound to to guide these kinds of interventions.
Thank you, Lisa. Dr. Beck, I just wanted to ask you a question that has been problematic in my mind. You know, Leo's pictures beautifully demonstrate these kind of spherical lesions, which are hyperechoic and very evident at the tip of the needle, and based on that, you know, move through the nodule geometrically to kind of encompass the disease to create this conversion to sphere by sphere to hyperechoic areas. But are those hypoechoic areas are the areas that are affected substantially by heat from the probe, but is there potential adverse heat that extends beyond that hyperechoic area? My sense would be, yes, it's just that the circle is the area that's been killed by the heat, and there are watershed areas beyond that that aren't killed, but nerves potentially could be very significantly affected. Can you comment, is there any modality on your ultrasound or other methodology that can show us not only the areas of hyperechoic necrosis, but of the heat, the extent of the heat from the needle tip? Or is it just judgment?
Yes, that is very important point. However, previous ex vivo studies shows the corresponding area, I mean the hyperechoic area is corresponded to definitely death after RF ablation. And I am agree with your opinion. You are worried about the spread of hyperechoic area. That is a kind of steam formed by heat. However, as you know, the thyroid capsule can prevent the spread of the outside the thyroid gland. So in my experience, this procedure is relatively, not absolutely relatively safe procedure by monitoring of ultrasound.
Mm-hmm. Thank you.
Mm.
Let me just open it up to the panel. Brendan or the panel, any other comments about Leo's case? Because I'd like to move forward with Dr. Beck's case once we've completed our thoughts.
Can I make a quick comment about the what Professor Beck was just saying about the recurrent laryngeal nerves? We did a series of 20 nodules early on under general anesthesia with continuous nerve monitoring. And we really had no significant changes in amplitudes of waveforms from those recurrent laryngeal nerves or vagus nerves. There was one medially placed vagus nerve in that series. The power we used, I didn't use any more than 40 watts, between 30 and 40 watts, but my criteria was making sure that that posterior capsule was kept free from the hyperechoic ablation zone. And as long as that ablation zone was kept clear of the capsule, we found no changes in vivo with regards to nerve potentials.
And that was using LAR, right, Catherine?
That's right, Brendan, yes.
Very good, thanks. And Leo, I enjoyed your case. You did a great job. And somebody asked in the audience if Leo had a follow-up picture, and he just did that case in the last week. But hopefully we'll have some follow-up pictures later in the presentation, or we'll get them to you later.
One other important point Leo, I think, demonstrated very well is taking the time to do the hydrodissection, lidocaine, anterior capsule, lateral part of the capsule, because this is an office-based procedure. Your patient, you want them completely comfortable, at least for 15, 25 minutes or so, sometimes even a little longer for the bigger nodules. You should set the expectations. They'll hear some popping and crackling. That's normal. You can tell them there's the treatment effect going on at that point in time. They may experience some jaw discomfort or even ear discomfort. And you want to try to avoid that with a good hydrodissection technique that Leo showed you can. But sometimes even for those posterior nodules, when you are going a little more posterior lateral, it's hard to avoid. So you can tell them to expect that, and usually they tolerate it quite well, and it's not more than an ache. So Leo, I'm glad you emphasized that, because that's kind of the setup before you actually do the treatment. Very important.
I would like to add to that. One, as Lisa told, I think the most important asset and skill that you have to acquire is the ultrasound mastery. As one key point I think it is, especially on those posterior nodules, is that you can really see as the needle enters the nodule, because if you, for accidental, even if you don't activate the electrode, but you puncture the posterior wall of the nodule, you can leak some hot liquid from the inside ablation into the longus colli, and that you will cause pain, and you cause this referred pain of this hot liquid onto the muscle. That is hard to hydrodissect. So you really have to really see the electrode entering into the nodule, so you can really predict and avoid this kind of unfortunately.
Great. Thank you, Leo. Dr. Beck, maybe you could share your screen now and start your presentation. But as you're doing that, I just wanted to ask Eddie Velto. Eddie Velto, any other comments on the technique or surgical indications for benign nodules?
Just a small observation. I do sometimes a little different from Leo, because Leo usually did just one function and changed the direction of the transducer. And I usually do 2 or 3 or more functions, and try to stay the transducer in the same lines. Just a small variation, especially large nodules, could be a good tip to facilitate, especially in the beginning of when you start.
Greg, you know, you're alluding to a great point. It's beyond the scope of this 1-hour webinar, but you know, when should we be doing surgery as opposed to RFA? The nodules get larger, higher volume. You know, when we start to think about 20 to 25 cc volume nodules, you know, maybe surgery is going to be better. You may need 2 RFA treatments. And so these are things that are, you know, things that we're getting more familiar with, but this is where you have to have this complete understanding of your options and what may be best for the patient ultimately.
I want to let Dr. Beck talk, but I really, Ralph, I think that's a tremendously important, you know, that anytime there's this new technology, you want to drive it all the way home, and that may not be the best way to introduce it. So I think that's a very sober and important comment. Dr. Beck, why don't we go ahead and have you present your case? And we very much appreciate Dr. Beck being with us. He's really a world leader in this, and we acknowledge that. That picture that I had in the very first introduction is from his some writing he's done, which we appreciate very much. So, Dr. Beck, the floor is yours.
Thank you very much. It is my great honor and pleasure to discuss thyroid RF ablation in this webinar. My conflict of interest. Today, I'd like to introduce radiofrequency ablation of recurrent tumor. This patient underwent total thyroidectomy and SND in 2008. 2 years later, he underwent MRND due to multiple recurrent cancers. However, in 2011, we found 2 recurrent tumors in right pipette. At that time, the serum thyroglobulin level was increased like this. And the ultrasound features show 2 recurrent tumors here and here. And this tumor shows intense enhancement on CT scan and very close to esophagus like this. So today I will introduce ablation of this recurrent tumor. The first video clip shows hydrodissection to separate the tumor and esophagus. And the second one can show radiofrequency ablation of this tumor. Here you can see the recurrent tumor abutting to esophagus like this. I used 21 gauge long SIBA needle for hydrodissection. You can see the separation of tumor and esophagus during injection of fluid, I used 5% cold dextrose water. You can see. Please remember the distance between the tumor and critical structures such as current laryngeal lobe. Please keep 5 millimeter. 5 millimeter, please remember, at least 5 millimeter. The second video clip shows the hydrodissection needle is in place, and I inserted another needle, that is RF electrode, to puncture the tumor. You can see the needle tip inside the tumor, and I lift up the tumor from the esophagus, and I continuously injected fluid during ablation. You can see the hydrodissection needle in place. When the distance more than 5 millimeter, I started ablation. During ablation, slow but continuous fluid injection. I planned to ablate the tumor and small amount of normal peritumoral tissue to prevent marginal recurrence. You can see the echogenic bubble inside the tumor. Continuous injection of 5% dextrose water. You can see the change of the tumor echogenically, and then change of peritumoral normal tissue. Here you can see the esophagus. You can see the wide ablation zone. At that time, I finish the RF ablation. So what about the serum thyroglobulin level? Before and after ablation, this is the 9-year follow-up. Thyroglobulin level shows undetectable. So this patient shows no tumor recurrence during 9-year follow-up period. So this is our revised RF ablation guideline. Here are my open questions about proper techniques and proper devices. First one is how to control pain. And what about the hydrodissection fluid? Dextrose water or a normal saline? And how to select proper electrode tip? Thank you for your attention.
Thank you, Dr. Beck, so much. We really appreciate that. This is really, I think, seeing that node being lifted up and hydrodissected, you're really manipulating that operative field, much as we would do in revision neck dissection surgery and central neck dissection surgery, but without having the advantage of having the entire field exposed. So my hat's off to you. Let me just, I think those questions that you posed would be important for the panel to weigh in on. Let me just start the questioning with a sense of, at least in the central neck, what would be the lower limit of size of lesion you would go for, and what would also be the upper limit? In other words, what would be the smallest node that you would go after, and what would be the node above which you'd say this is a little bit too big for RFA, in terms of just recurrent PTC, central neck lymphadenopathy?
In my opinion, in our practice, lower limit of the size is 5 millimeter because we have smallest active tip is 4 millimeter. So to minimize surrounding structure damage, we treat the lower limit size of 5 millimeter. And in terms of upper limit, big tumor is very difficult to treat without critical structure damages. So we use a combination therapy. First, we apply the RF ablation, followed by TKI or sometimes radiation therapy. So in my opinion, big tumor is there is no absolute.
Let me just push you on that a little bit. What is the size range in general above which you'd say RFA as a separate isolated therapy is not effective?
The size is not concern. The concern is the invasion of trachea or esophagus. That means separation is impossible.
I see. Okay, very good. Very good. Lisa, do you want to comment on the injectate? Do you use D5W? Do you use saline? When do you use lidocaine? Ralph had mentioned lidocaine in the anterior capsule. What is your menu of injectates and where do you use them?
So thank you. I would say that after Dr. Beck's tutelage, I have only used D5W as an alternative to lidocaine. I appreciated Catherine's comment very much about not using lidocaine against the trachea or in a location where you wouldn't want to cause even temporary nerve dysfunction such that you couldn't monitor. You don't want to inject lidocaine too close to the vagus nerve or the sympathetic trunk. So I use lidocaine for superficial structures very liberally. I find that the sensitivity is greatest in the superficial aspect of nodules, and I think you have to be very careful as you get close to the skin. And the trachea is the other sensitive area, as Dr. Sinclair mentioned, and that's where I tend to use D5W. I don't have personal experience with using saline as an alternative.
Dr. Steck, can you describe your pattern of injectate and where you use what?
Okay, thank you for the invitation and thank you for the question, Randolph. Yeah, usually in the anterior part of the surface of the nodules, I use lidocaine with taking care, because I had two times a case that even not injecting the lidocaine much lateral or posterior, the patient developed temporary paralysis of the laryngeal nerve. So I could diagnostic this because the patient was awake and was talking to me, and suddenly they became with a hoarseness. And this is a very important concern when injecting lidocaine, because if you are planning to do both sides of the thyroid or both sides of the trachea, you need to avoid bilateral paralysis, even if it was temporary, right? So I am very careful to inject lidocaine just in the anterior part, and always monitoring the patient with the hoarseness and the patient is awake. In the posterior part, I use the dextrose too. I do not use saline. I think maybe saline can be a good conductor to the ablation area. Maybe it can expand the ablation area, and dextrose I think is better to avoid this.
Very good. Let me turn a little bit to a general question of ultrasonographic follow-up for Edivelto. When you are treating, say, to jump back to a benign nodule, what is your pattern of ultrasound? Do you wait a month or 2 months for your first ultrasound, or and how many follow-up ultrasounds? A patient is followed indefinitely. When is the first ultrasound?
Usually, I perform the first ultrasound after 1 month, usually. And then every 2 or 3 months, depends on the size of the nodule. After 1 year, 1.5 years, the patient reach the peak of the shrink of the nodule. So after then, it's not necessary you do frequently the ultrasound. So you can get more relaxed and do the ultrasound once a year.
Mm-hmm.
Okay, but may I do a comment, Greg?
Yes, please.
I want to ask to Leo and Dr. Beck and all the panelists, because I used to use cold dextrose as a routine, not a room temperature dextrose. I want to know the thoughts of Dr. Beck and Dr. Rangel and everyone about the what's the temperature of the dextrose that you use.
Dr. Beck, can you take that
Yes.
first, and then we can hear from Leo?
Yeah, yes. I usually use temperature less than 4 Celsius degree, very cold water.
As a routine.
And non-routine. I prefer, but non-routine.
Leo?
I just use the cold saline as a backup if I have any voice changes, as Dr. Beck described it. On hydrodissection, I use normal temperature.
May I just add that I think we all are cognizant of not causing lidocaine toxicity. So that's the other limiting factor. And I started out using a higher dose of 2% lidocaine, but have found that 1% lidocaine provides sufficient anesthesia, and you can certainly use a lot more of it, so you get more hydrodissection along with the numbing. But that's really, I think, the limiting factor is being cognizant of how many milligrams of lidocaine we're injecting.
Leo, let me ask you, one of the things, this is, at least for, in your case, for benign nodules, often cosmesis is part of the rationale of the surgery. And so a skin burn would be, to not successfully treat the nodule is one thing, but to get a skin burn in a young woman's neck who's coming to you for a cosmetic issue is really pretty problematic. What methods do you use to make sure it's a matter of kind of same as using a scalpel, you grab the handle and not the sharp end. You have to know how to use the instrument, but how do you make sure you know where that tip is and make sure that it isn't right underneath the skin and could cause a skin burn?
Greg, your comparison to the scalpel is perfect. Yes, and I do it all the time. As surgeons, we cannot blame the scalpel. Yeah, we have to blame ourselves. So having this set, having the ablation area distance from the tip into any direction is about 3 millimeters. So it is safe if you have, as Dr. Beck said, at least 5 millimeters from the ablation, from the electrode tip, the active tip, to the area that you're concerned. You're safe. You don't have an area. So if you're ablating, and that's why it is important to use the moving and shot technique, because if you position the electrode and activate it, and if you're concerned, you stop the ablation and move and reposition, recheck the position, then you activate again. The way I do it now, as people get used to the procedure, and you can retract the needle as you're doing the ablation, is a little bit more advanced. You should do this only when you are very comfortable with the needle and you're seeing the needle all the time, and when you're more experienced. When you're starting, I really encourage to do the movement shots.
So I'll open this. I'll open this up next to the panel. Is that Virginie Atchim has asked a question: does RFA affect future surveillance ultrasound for the PTC? And I'm just going to put a little spin on that. That, you know, one of the reasons why, at least in my unit now, we tend to operate on sizable toxic nodules rather than give RAI is because the RAI turns the nodule into this big, ugly, calcified lesion that the endocrinologist just can't stand to look at year after year after year, and ultimately they biopsy it, and often it will show some suspicious changes. You are similarly creating nodules that are now ablated and abnormal in their architecture unless they're completely gone. Does anyone have experience in the long-term ultrasonographic findings and repeat needle biopsies of previously ablated nodules? Is it problematic? Does the ablative maneuvers engender some atypical changes that is problematic or not really? Dr. Beck, maybe I'll ask you first, and then Leo, and then open it up to the panel.
Yes, that's very, very good question. So we published the long-term follow-up ultrasound features that shows very irregular, that means suspicious ultrasound features. So we collected biopsy cases during follow-up period and reported about 30 cases of biopsy after RF ablation shows no absolute change of cancer. So we believe it. Initial definite benign nodule is stable for long-term follow-up period.
Great, wonderful. Well, I think we're basically running out of time. I want to gather up the panel. If anyone feels the need to make a final comment or thought, that would be, we'd love to hear that. I want to thank all of the panelists, especially Leo and Dr. Beck. Very much appreciate their wonderful educational videos and presentations, and they've taught us all a lot. This session is recorded, and so if you get in touch with me or Betty, we can make sure you have access to that. Betty will be sending out an evaluation form, which if filled out will result in distribution of some CME. And again, I'm very happy to say the endocrine section is really got a very vibrant set of webinars, and we will be looking forward to seeing you with some of our British colleagues in December. Brendan, anything else we forgot to mention?
No, thanks everybody for attending and supporting the American Head and Neck Society Endocrine section.
Okay, very good. With that, I guess we will adjourn. Thank you so much, everyone, especially Leo and Dr. Beck.